So, good evening to everyone who's listening later. Dr. Gardner is a professor and chief of colorectal surgery at the University of Minnesota. He holds the Stanley Goldberg Endowed Chair in Colon and Rectal Surgery. He completed general surgery residency and his colorectal surgery fellowship at the University of Minnesota. He is actively involved in both clinical and translational research, and he currently serves as the chair of the Clinical Practice Guidelines Committee His research interests include colorectal oncology, minimally invasive surgery, peritoneal carcinomatosis, and the human microbiome, and we're very lucky to have him here today.
Thank you very much for the invitation and for that introduction. Well, it's Sunday afternoon, so welcome to those that are live. And if you are seeing this as a recording, hopefully it's useful for you as a general view of appendiceal pathology, mainly from a colorectal surgery perspective. Shameless plug, the appendiceal neoplasms CPG has been published online since April and soon to be on DCR, obviously. So there's going to be a lot of those statements and recommendations and the data set that we use to formulate those guidelines. And let me know if it's not moving through. These are my disclosures, of which none of them will influence what I'm talking about today. We all know that we study this as a medical student and a resident of the embryology and anatomy of the appendix, and everybody remembers that kind of diagram of the position of the appendix, and it's kind of fun to know like it has different anatomic positions, and when you see this during appendicitis when you're a junior resident, you're like, oh, okay, that's where it comes from. But it's a true diverticulum. Everybody talks about that kind of anywhere between 4 and 15% of immune function that usually goes away after a couple of years, and it's debatable whether that it's even useful in any way or form. There's been the recent speculation of its immunity function, especially with the randomized controlled trial that's happening in Europe for ulcerative colitis and how that influences disease progression or not of inflammatory bowel disease in general, which that hasn't really caught on in the United States as much, but I think it's being discussed, so it's still inconclusive. And the other thing is that it works as kind of like a safe house for symbiotic gut microbiomes. One of my partners, Dr. Johannes, talked to you a few weeks ago about the human microbiome and how that influences gut health and recovery after surgery, and the really interesting things we're doing at the University of Minnesota with regards to kind of transitioning or altering the microbiome in those patients. So let's focus on appendiceal malignancies. These are quite rare. I mean, if you think about it, it's like 1% of all GI malignancies. It's most frequently diagnosed in appendectomy specimens, or if somebody's doing intraval appendectomy during an operation. There's really not a distinctive clinical presentation. You know, those things that you read about when people have more like adenomucinosis or jelly belly of distension and stuff like that. Those are usually in very late cases, and it's not as common as if, you know, when somebody just presents with acute appendicitis, which I would think is probably the most common clinical presentation. If you think about it from what epidemiological data, let's 0.4 to 1.9 per 1 million, it's slightly more frequent in women. And what we've recently seen, and this was a paper that was published from the University of Minnesota not too far, about 10 years ago, that we have seen an increase in mucinous adenocarcinoma. And this is an increase despite mucinous adenocarcinomas in other parts of the GI tract, especially the colon and the rectum. This is an interesting paper from about 5 years ago. So this is from the University of Manitoba, looking at the incidence of appendiceal neoplasms. They looked at the SEER database, but as well as the Canadian Cancer Registry. And overall, despite having stable appendectomy rates, because I know that a lot of people are treating appendicitis more non-operatively currently. So despite having stable appendectomy rates, you can see that almost, you know, anywhere from 230 to 290% increase. More so for adenocarcinomas and neuroendocrine tumors. This was across all age groups, genders, and stages of disease. And the highest increase that they saw was neuroendocrine tumors in the youngest age group, somewhat in the 30s to mid 40s in these patients. And what is important to state is that there was a stable appendectomy rates during the study course. If you look at specifically adenocarcinomas and neuroendocrine tumors, and you categorize them by year and age groups, you can see the increases, and quite noteworthy of the neuroendocrine tumor on the bottom, kind of mid portion, as you can see those lines kind of going up straight, that we've seen the biggest incidence of that. So in general, to expand on that, and this is kind of like something that we wanted to tackle during our literature review for the CPG that we recently wrote, is there higher risk with increasing trends of non-operative treatment and management of appendicitis? Well, we learned that the data is pretty poor on this. There are some randomized controlled trials on operative and non-operative management of appendicitis, but they are not focused on treatment of appendiceal neoplasms overall. But there tends to be an equal incidence when it comes to complicated and uncomplicated, mainly perforation, abscess, and phlegmon. The main risk factors, and these are mainly retrospective, is obesity and an age above 40, and that's from the a larger NISQUIP trial and one single randomized controlled trial. One meta-analysis of 7 retrospective studies and one randomized trial showed a pooled prevalence of about 11%, but it went up to 16% in those above 50. You can see the distribution, which is mainly epithelial neoplasms, mainly low-grade appendiceal mucinous neoplasms, which I'll refer to as lamins during the talk, adenocarcinomas and neuroendocrine tumors. Goblet cell carcinomas, deserve their kind of specific attention separately, and I'll discuss those a little bit at the end of this talk. And you can kind of see the distribution and rate on the table to the right, which varied anywhere from 9 to 30% of the specimens in the appendectomy specimens in general. So for our CPG that hasn't been published yet, we do interval appendectomy after a complicated appendicitis is typically recommended. You're going to see a lot of these typical, commonly, frequently words that we use in CPGs, and there's a reason for that to not be prescriptive with our statements or recommendations, because obviously we really value the clinical care and evaluation of these patients, but we typically would recommend an interval appendectomy in adult patients over the age of 40, or if there's interval imaging findings that suggest more of a malignant process or a phlegmon that's not getting better, a mass, et cetera, because of the risk of occult malignancy. And this was a conditional recommendation based on low quality evidence like we're talking about. All these patients, when they have an appendicitis, especially the complicated appendicitis, we always say, just kind of like the diverticulitis patients, like wait a couple of months. And if the patient hasn't had a previous colonoscopy, or it's been more than anywhere from 3 to 5 years, we would typically recommend that. The data on this specific topic or subtopic is even worse. So what is the role of patients in that kind of screening age of colorectal cancer? Well, it's really poor. It rarely defines any type of appendiceal neoplasm, because for those of us that do colonoscopy, it's not like you can really see. Sometimes you can see a little bulge, or people frequently, label it as some mucin, for example, coming from the appendiceal orifice. The reality is that's just so biased and that's so uncommon that it's unreliable. But what is true is that there are epidemiological studies that with patients with appendiceal neoplasms, up to a third of those patients will have adenomas. So even if it doesn't change the categorization of your appendiceal neoplasm, a lot of these patients will have metachronous adenomas in the rest of their colon and the rectum. So for our recommendation or statement within the clinical practice guidelines, we do recommend colonoscopy in patients with confirmed or suspected appendiceal neoplasm. This was a strong recommendation, but it was low quality evidence, as there's not a lot of prospective data on this. I think the best thing that's happened to appendiceal neoplasms recently is that we report them better. And this is mainly due to the World Health Organization and multiple pathology societies that categorize it better. The most important thing, as I see somebody with appendiceal cancer, is having the value of an experienced pathologist, specifically a GI pathologist that regularly sees appendiceal neoplasm. That is the number 1, 2, and 3 things that we value during tumor board discussions. In general, we divide them in epithelial and non-epithelial. The epithelial ones get divided in mucinous and non-mucinous. The World Health Organization, you can see, classifies the epithelial lesions into low grade, into high grade, and adenocarcinoma. So you got to think about those as 3 different entities of the mucinous neoplasms. And I think it's important for people to understand that adenocarcinomas of the appendix resemble the counterparts in the colon and rectum. So these are the typical things that we are typically looking at when people have carcinomatosis and they've had a biopsy of the peritoneum. We can test for P53, CD44, and CDX2, because some patients can have carcinomatosis of a different primary origin or occult origin. And sometimes they've already had an appendectomy. I've literally seen a patient with carcinomatosis which the biopsies were read as consistent with appendiceal primary when the patient had an appendectomy more than 5 years before the diagnosis of that. Now, how does that how does that actually even happen? Who knows? There's a lot of process of dedifferentiation, sometimes even with colorectal tumors or occult primary tumors. So those things still happen, but I think it's important to know that they should resemble their colorectal counterparts. Shameless plug of this book, if nobody's read The Peritoneum by Di Sarega, this is a really, really helpful kind of short review of the peritoneum in general, the physiology, anatomy, and its function, and it helps play a role in cancer dissemination. Goblet cell carcinoids, and we don't call them carcinoids anymore, but carcinomas, is a variant of an adenocarcinoma with neuroendocrine features. They tend to be more aggressive than the traditional neuroendocrine tumors. They tend to metastasize transalomically through the peritoneum. And the most common sites of that is typically ovaries in women and in general peritoneal surfaces. How do we classify the actual metastatic disease? Because I think that's important when we're talking about appendiceal neoplasms. The lymphatic spread is less common with mucinous tumors in general. Hematogenic spread is more common with the high-grade neuroendocrine tumors or even the goblet cell carcinomas, as well as the signet ring cell adenocarcinomas. And you'll see that sometimes people want to fit these tumors in a box, and because of that process of dedifferentiation, where you can have a lamin that goes from lamin to high grade, or even a high grade that becomes adenocarcinoma, or even down the road when people have progressive metastatic disease of their peritoneum, they later in their disease process they find signet ring cells, and it's not because it's a different tumor or you miss something, but this is how that malignant process evolves over time. Sorry. What is really associated with peritoneal involvement is definitely an advanced T stage or perforation of the tumor. In general, we tend to differentiate pseudomyxoma peritoni based on the cellularity of the mucin. And what is important to know is that cellularity of the mucin, when you're doing, for example, a lot of people want to send like a peritoneal cytology during the operation. The cellular portion of the mucin cannot be defined on a frozen section. So if you're thinking that you're going to send this, that's going to change your mind intraoperatively, how you're going to treat somebody with an incidentally found, perhaps low-grade mucinous neoplasm or any type of neoplasm of the appendix, you really cannot make that decision intraoperatively without waiting for that final pathology. And on the table on the right, you can see how the classification based on histology of PMP is described into low grade, high grade, or actual carcinoma with signet ring cells. And that's depending on the criteria that I'm not going to list through, but you can see them on the right side there. In general, we talk about it as low grade and high grade in those patients. So back to the guidelines. So let's focus on appendiceal neuroendocrine tumor for a second. The surgical treatment will depend on the tumor size and its histologic features. For a tumor that's less than 1 centimeter, in general, appendectomy alone is the treatment. And a lot of these patients don't even need any surveillance afterwards. So all the chromogranin A levels and dotatate scans and all those things for those patients, in general, NCCN guidelines don't typically support that for very low grade, well-differentiated, less than 1 centimeter neuroendocrine tumors of the appendix. Now, 1 to 2 centimeters with high-risk features, it really depends on the degree of these are kind of like the fancy things that people have come out with over the time. Now, how valid are these things? They're based off of larger retrospective studies. We don't have any randomized controlled trials of surgical treatment of appendiceal lesions, and there's very poor data in general for this specific subgroup of the neuroendocrine tumors between 1 and 2 centimeters. But these are the things that you're going to see on your boards, and they're going to frequently ask you these things probably during written exams. But a high risk feature would be a mesoappendiceal invasion more than 3 millimeters. If you have above 2 mitosis per high power field, lymphovascular invasion, and even more fancy is a KS67 index above 3%. This is actually kind of a target that's changing a little bit with newer publications that some people even refer to up to above 5% versus 3%, but it's something to keep in mind. And I'm going to expand a little bit more about that kind of middle group of patients too. And then in general, for neuroendocrine tumors above 2 centimeters, we typically do recommend right colectomy because there's up to a 40% chance of risk of lymph node metastases. Now, this is a topic that probably deserves a little bit more debate, and I think we're going to see more and more data on this in the future. What's the significance of a neuroendocrine tumor metastases in the lymph nodes over time? We're actually seeing that even those patients that don't undergo a right hemicolectomy that are later proven to have metastases to the lymph nodes have equal survival. And we don't understand that quite yet, why that happens. This whole categorization of size for appendix tumors is so antiquated, and it makes me cringe every time I think about it. But it's the best data that we have currently to depend on the literature, especially when you're developing guidelines for these neoplasms. This is the European Neuroendocrine Tumor Society classification. We also included a table, I think it was this one or something very similar to this, that compares that with AGCC classifications, but it really depends on size and T class. And looking at infiltration of the mesoappendix, 3 millimeters is the buzzword, whether you do an appendectomy or right-sided hemicolectomy. I think that the one aspect that we defer in, especially with European guidelines, is that there's a lot of push for even the tumors above 2 centimeters that are well differentiated and low grade, that a lot of these patients should be treated with appendectomy alone because their risk of lymph node metastases is significantly lower. The other thing is, as you can see there in location, tip, middle, or base, for whatever reason, people believe that when these tumors are at the base, they have like different biologic behavior, which I don't completely understand why. It's pretty obvious that if you have an R1 resection or a microscopically positive margin, that you should probably go back and do a right hemicolectomy. As some people even debate whether even to do like more of a formal cystectomy or ileocolic resection. The data is really poor on that, and it's going to be really hard to have any prospective data on that because of the rarity of these tumors. But I think those are the two topics that the more Western and European data sets and guidelines are going to have significant differences, just so the audience is aware of that. And that may be a changing paradigm. This is what I was going to talk about like those 1 to 2 centimeter tumors. This is a large European experience of those specific 1 to 2 centimeter neuroendocrine tumors, where you can see 59% had an appendectomy, 41 had right hemicolectomy, really good follow-up. They found regional lymph nodes in 20% of patients with the right side, so lower than what had been previously published. But what was most important in these ones, when they looked at overall survival, even when they excluded patients with more advanced tumors, there was non-statistically significant difference in the overall survival of those patients who underwent appendectomy or right colectomy alone. And this is probably why the guidelines in Europe typically recommend just appendectomy for these patients. But I still think it's important to discuss these tumors at tumor board sessions or a multidisciplinary kind of setting, and obviously have really good input from a pathologist, an expert pathologist that sees appendiceal tumors frequently. So I'm just going to talk a little bit about 3 different statements or recommendations from the guidelines specifically on NETs. So neuroendocrine tumor specific imaging should be considered in those patients that have more of an advanced tumor that present with carcinoid syndrome because it detects metastatic disease better in those patients. And this is a conditional recommendation based on moderate quality evidence that we're seeing more and more. My personal opinion on that is that I try to avoid getting dotatate scans on a lot of these patients, especially the well-differentiated or low-grade tumors. But when I'm worried about whether there's persistent disease, and obviously it's never perfect, but a lot of these patients get a diagnosis of a tumor. Somebody thinks it's a great idea to order a CAT scan right after the appendectomy. Everything's kind of inflamed. The lymph nodes are slightly enlarged. The radiologist is non-committal with their description. And usually these are younger patients, and it makes parents like really worried. And so a lot of times I have to succumb to the net specific imaging more so because of that shared decision making with these patients and their families. But usually in the surveillance process of that, once we know that these there's no significant findings of spread, you could use CT or MRI. It doesn't have to be a neuroendocrine specific imaging. We typically do recommend biochemical testing, but it shouldn't be routine. For patients that definitely have documented metastatic disease, it more so having it as at a baseline. I think it's helpful when you follow these things over time. There's more and more on liquid biopsies and ctDNA, and even there's a new test on a type of ctDNA for peritoneal fluid. I'm really not going to comment on that because it's mainly investigational at this point in time. But I think that we're doing a good job at identifying better tumor markers. We've had like CEA forever, and then CA 19-9 and CA 125. And we know that when they go up, it's not a good thing. But when they're in that middle range or they bounce around a little bit, they're very non-specific, and we don't know what to do with that. Surveillance in neuroendocrine tumors with curative intention involve physical examination, biochemical testing in general, and then you can use either CT or MRI. But then again, I personally don't use a lot of neuroendocrine specific imaging, specifically the dotatate scan in those patients, because it usually doesn't change what I'm going to do. Okay, so that was neuroendocrine tumor. We're going to talk about epithelial neoplasm, which are by far the most common ones. The workup typically involves, and these patients are typically already worked up by an oncologist or a general surgeon that got a lot of imaging right after the appendectomy. But CT and MRI are pretty equal. I personally favor MRIs in these patients because they're usually younger patients and they usually get a bunch of scans, like many, many scans. And so I prefer MRIs mainly because three things. One, there's no radiation to the patient of someone that you know is going to be radiated a lot. Number two, I have a great team of MR imaging, body imaging people that find it more useful for them than a CT scan, mainly to detect mucin, because there's hydrogen in that, and that is readily detectable in T2 signals for MRI, so they see that a lot better. We do typically get all of these tumor markers. How that changes what we do, not much. It's more to have a baseline and how it responds to treatment. And especially in those we think may have disease progression, the changes in that could influence the way we manage that. Like I mentioned, I typically do not get peritoneal cytology. There's more data on ovarian epithelial cancers where it may be useful in those patients, but it rarely influences the way I'm going to treat someone. And it really, to me, bottom line, it depends on what the pathology showed on the primary tumor and not of the mucin or whatever fluid I aspirated during the operation. Specifically, mucinous neoplasms, please do not call these mucoceles. If you see that on a radiology report, that is a lamin until proven otherwise, and it should be managed as such. It is okay to remove these, and typically there's really not a lot of benefit at all, actually, in doing that formal right hemicolectomy for these neoplasms. So it's usually a minimally invasive approach where you're doing an appendectomy, where you're trying to get as much cecum that the ileocecal valve will allow you to get. Use an endocatch bag because these rupture. Be careful with intraoperative manipulation. These are not the intern case where you can just kind of grab and fracture the tumor. That's bad. What about those patients that get sent to you because they have a perforation or they see a little bit of mucin on the outside of the appendix or on the area located like in that fossa without having gross dissemination? There's really no evidence to show that. Actually, there's evidence on colorectal cancer, but not appendiceal. But in general, there's no evidence that supports prophylactic HIPEC in these patients. For me, peritoneal cytology is pretty useless in that situation, especially what we discussed about with the frozen section or sending it intraoperatively. And there's actually increasing data to show that safe data on careful surveillance in these patients. We are probably going to publish this pretty soon, but with our experience, patients that have had perforation and they don't have any residual disease and did not have adenomucinosis, the great majority of those patients are offered imaging surveillance as long as there's no evidence of like adenocarcinoma or a positive margin, for example. But with very localized area of mucin, it's very safe to do close surveillance on those patients. And if your imaging surveillance shows something, our protocol at the University of Minnesota typically involves like diagnostic laparoscopy if there's any changes in the imaging. And we have not shown any difference when it comes to disease progression or overall survival or even disease-specific survival, even if we catch that during an MRI, for example, or tumor markers. When this is how the board exams always try to trick you, they say appendiceal adenocarcinoma, but then they say like 0.9 centimeters. If you read adenocarcinoma, it's right hemicolectomy with a regional lymphadenectomy, no matter how you put it in these patients. There's some debate that when people have like the full treatment of like an appendiceal adenocarcinoma that is a pretty extensive metastatic disease in the peritoneum, there's less and less benefit of actually doing a right hemicolectomy when we know there's already spread to the peritoneum. So in selective cases, you can forego doing a right hemicolectomy in the setting of an appendiceal adenocarcinoma that has peritoneal involvement. This is a patient that you're already doing extensive cytoreduction on. You're doing HIPEC. They're probably going to get IV chemotherapy. If there's no clear evidence of any positive lymph nodes within that ileocolic area or seen on imaging, adding on a right hemicolectomy already in a very advanced stage of disease has shown questionable benefits at best. And you're just adding an anastomosis in a very long operation that may cause the patient more morbidity. There's very little data supporting what I just said, but in general, a lot of high volume HIPEC centers agree with that. 67% is pretty high in general. People think about it somewhere closer to 40%. I really, this is more data, really early on data with more advanced tumors. I think with the advent of like axial imaging and stuff like that, and everybody getting an appendectomy gets a CT scan, I would say it's closer to the 20% than the 67%. And this is what I just said, in the setting of peritoneal spread, right colectomy does not typically confer a survival benefit, but there's really not a lot of data supporting that. Okay, talking about LAMs in general, lamins, our recommendation in the 2025 guidelines is negative margin, no evidence of perforation or peritoneal involvement, appendectomy alone. Okay, you do not have to do a right hemicolectomy. I don't know how many times I've been called into the OR during an ovarian routine for what was suspected to be ovarian cancer, and it was a tumor in the appendix. They found it, and they're calling me in to do a right hemicolectomy, or even worse, they've already done it for you. If this is a lamin, which is typically is, there's really no survival benefit in adding more of an oncologic resection as long as it truly is a lamin. How do we categorize peritoneal involvement? I think this is important for people who are just starting out or not doing a lot of appendix work or HIPEC work in general. They're not at a cancer center. If you're going in to do an operation where there's unsuspected peritoneal involvement, and this can be from appendiceal or colorectal in general, just print out this PCI thing and just try to put this in your operative report. It is so helpful for people to actually look at all these segments, run the small bowel, and try to categorize the peritoneal involvement as best as possible, because that will definitely influence the type of treatment that will proceed. Whether we start with chemo or we come back and we do HIPEC after this, or just cytoreduction, but having that PCI is extremely helpful. Cytoreduction is generally indicated for the select patients with appendix neoplasms and evidence of peritoneal involvement. This is a strong recommendation, but the data is of moderate quality. Real goal of this is you have to eradicate all macroscopic disease. The selection of this is crucial. We always talk about it at like a tumor board session. There's some evidence to show that more of an experienced center that does HIPEC. I generally agree with that concept. I know that can be, anybody can remove the omentum and do a limited cytoreduction, yes. But for somebody that's doing it more frequently, I think the thought process and having a multidisciplinary setting or care for those patients has translated in better outcomes. We typically perform prophylactic omentectomy regardless. I remove all these patients. I tell them before because this is important. This is a very common area of recurrence. So their umbilicus gets removed, their falciform ligament gets removed prophylactically. And this is important to understand too. There's actually been 2 or 3 studies, both from the US and the UK, showing that occult metastases to the ovaries because of that transcelomic pathway occur in 17 to 45% of ovaries. And this is even in the setting when the ovaries appear completely normal, so micrometastatic disease. So this is a conversation that has to be done before the operative treatment. Obviously, recurrences are common with peritoneal involvement. It really depends on the histology and the extent of disease. And just to reiterate, we cannot establish on frozen section between what would be more of a high grade, mucinosis versus a low grade, which is the acellular mucinosis in those patients. This is what really drives survival in these patients, especially the ones that have actual carcinomatosis, is the completeness of cytoreduction score. The only reasonable way to success is a CC0 or 1. But if you're leaving CC2 or 3, so gross metastatic disease, there's no reason why you should be doing cytoreduction in that situation. Now, have I been surprised in the past where I feel like it's a low PCI, I think I can get it all, but then there's critical lesions. And when I say critical lesions, I mean enough carcinomatosis that would require, for example, a pelvic exoneration or maybe even a Whipple, or there's involvement of liver vascular structures. There's a ton of involvement of hepatic triad, for example, or diffuse small bowel involvement. Those are situations that we really cannot cytoreduce adequately. And there's a lot of value in doing diagnostic laparoscopies on these patients to not confer the morbidity of a laparotomy and trying to establish whether you can get it all, quote unquote, and establish that PCI with minimally invasive techniques. We're not going to kind of touch on every single aspect of HIPEC. And I know a lot of people want me to cover the Prodige 7 trial, which is quite interesting, and I've reviewed it extensively. But just so everyone knows, the Prodige 7 trial did not involve appendix neoplasms. There was, after I talked to the authors, there were a few that were not mentioned that, and I think it was 6% of the total population. And they don't even know if that was the primary or not. So trying to extrapolate the data from the Prodige 7 trial to appendiceal lesions, I think is an error. And even though a lot of us do believe in that HIPEC may not confer additional benefits, there's really no trials that has answered that question for us. We typically do like a closed technique in these situations. This is our recommendation or statement on HIPEC. Intraperitoneal chemotherapy after adequate cytoreduction compared to surgery alone may reduce peritoneal disease recurrence, although its impact on overall survival has not been well established at all, and it definitely increased cost and toxicity. So as you probably saw from the Prodige 7 trial, about a third of those patients had a very serious morbidity because of the chemotherapy. And obviously there's increased cost of the chemo. To reiterate, there's really no randomized controlled trials on HIPEC for appendiceal cancer exclusively. There's, it's quite interesting on like everybody's kind of doing slightly different. There are two societies globally that are trying to answer these questions, but everybody's kind of doing their own thing. But there's really no consensus on what drug is better, what technique is better, what's the temperature that we should be using, or even what's the adequate duration of exposure. So just take that with a grain of salt as you're looking at this. And in general, not just for appendiceal lesions, but for colorectal cancer as well, there's no convincing evidence that prophylactic HIPEC helps. And even from the ColoChip trial, for a lot of people that have kind of read a lot of HIPEC stuff, for those with very advanced tumor, like a second look laparoscopy or laparotomy in those patients was also non-warranted. It did not change the way those patients were treated, even when they got adequate cytoreduction. I think there's a lot more interesting data, especially coming from Memorial Sloan Kettering and Dr. Garrett Nash, that I think is going to publish soon on early postoperative intraperitoneal chemotherapy. That's the definition of IPEC. So you're doing cytoreduction, you leave a catheter behind, and for 3 to 5 days, you give some sort of chemotherapy right after. And they're doing this quite more. I think the experience is better with ovarian cancer that has shown some positive results. Ovarian, even very specific type of ovarian cancers with very specific extent of disease. most gynecology oncology groups were going away from PIPEC or intraperitoneal chemotherapy in general. And it's had somewhat of a little resurgence because there's data showing that there may be improved survival in select patients. So I think we're going to have more data on that soon. Just go back 1 second. There's one thing that people read about and people love talking about this that's called pressurized intraperitoneal chemotherapy or PIPEC. There really hasn't been any prospective or randomized controlled trial on that. I reviewed the data recently, and there's probably some promising select groups that are probably they're showing results that are encouraging. But I do not perform PIPEC. I think that's somewhat of a minimally invasive technology for this that may hasten like the progression of disease that is not cytoreducible may become promising in the future. A lot of people are saying that the people are non-resectable can become resectable with PIPEC. I think the data on that is very unclear at this point in time, so I do not perform that. But I'm very encouraged by seeing these results, and I'm encouraging these groups to publish more of their of data, hopefully prospectively. This is what I was talking about with low-grade mucinous neoplasms with like a perforation of a positive margin, which by far is what I see the most. This was a prospective trial of lamins just had appendectomies. You can see kind of what they saw intraoperatively. These are very small numbers. And these patients were just followed with CT scans. They had a median follow-up of 5 years. None of them developed adenomucinosis or PMP over time. This is the University of Toronto group, which is a very large appendiceal high-tech group that also is a major referral center for the east of Canada. And in their situation, really a repeat operation, especially in the presence of this low-grade appendiceal mucinous neoplasm, had excellent survival with just surveillance alone. And most of these patients did not require another operation and had overall very good survival. This is an Italian study. I think this is a larger one too, less than 50 patients though. Limited peritoneal spread. I think a lot of these centers have converted from CT scans to MRIs and are following patients a lot longer. Some of these recurrences can happen 6 to 8 years after. So you got to think about that if you're not offering them non-operative management. Many of them had appendiceal perforation. You can see that pretty decent follow-up, and only 5% peritoneal recurrences, of which all of them were detected with serial imaging. A couple words of caution with especially mucinous epithelial lesions. We're seeing some, and this is not causation, but association or correlation, I should say, with infertility drugs and low-grade appendiceal mucinous neoplasms. This is an active topic of research of mine that we're looking at, so that there might be more data on that, but just a word of caution. Like I said, with occult metastases in women, when both ovaries are normal, there can be up to a 13% chance of micrometastatic disease. And typically, I'm recommending, as long as it's age appropriate, and we've discussed it preoperatively for prophylactic bilateral oophorectomy in those patients, even when they look normal, and 20% when one is macroscopically involved. I told you guys I would dedicate a slide or two to that, like goblet cell carcinomas or even high-grade mucinous neoplasms. One area of caution as well, that high-grade mucinous neoplasms in the European guidelines, it's debatable whether they will offer them right hemicolectomy. Our guidelines do recommend a formal right hemicolectomy when you have a Hammond. And this is really dependent on an experienced pathologist reviewing it in a multidisciplinary session. We recommend right colectomy, but as I said, the guidelines may differ. Goblet cell carcinomas are really interesting. You see these patients, they've had an appendectomy with or without a positive margin. We typically recommend right hemicolectomy. And the great majority of the time, we don't see spread to the regional lymph nodes. And their disease is so odd that, 2 years after having a R0 resection where they had zero lymph node involvement, and they'll have metastatic disease in the liver. And they, typically they don't get chemotherapy. So I think there's a lot of debate with the goblet cell cancers currently on how to have better surveillance for these patients compared to what we normally do for the common appendiceal or colorectal cancers. This is an NCDB kind of retrospective review, obviously, of 1,000 patients where the majority had right hemicolectomy. And the lymph node positivity did increase, obviously, with the T stage. Appendectomy surgical margins were positive in about almost 20% of those patients. When they looked at the survival benefit at 5 years, pretty, even though it's statistically significant, I mean, offering 82 versus 85%, and really depends on overall survival. This was not disease specific survival, or if they had recurrences, was it this caused by recurrence of the actual disease, or this just overall survival benefit? But you can see that, for the earlier cancers on the lower graph there, it was very similar when you had T1 or T2 goblet cell carcinomas. And I think that's an actual field of debate currently within appendiceal neoplasms, whether those patients actually need a formal right hemicolectomy. And then for the T3 and T4, even though it was 0.02, it's not that drastic of a difference. So I think we can do better there. How does systemic chemotherapy get involved in all these things? I'm not going to spend too much time on this. It may improve survivals in patients that have known metastatic disease, that are lymph node positive disease, that have Hammonds in the adjuvant setting, or with peritoneal metastases. For patients that have lamins or well-differentiated cancers, without peritoneal spread, we do not typically recommend chemotherapy. This was a strong recommendation based on low quality evidence. There's no level 1 evidence on this. On lamins, for patients that we've already done cytoreduction or even HIPEC on that have recurrent disease, where maybe in a handful of patients we've done recurrent or repeat cytoreduction, a lot of these patients will be placed on like Xeloda, just to kind of halt the progression of their peritoneal disease over time. But in general, typically we do not recommend chemo for lamins. And the timing of the chemo is just another kind of box that there's really no perfect answer for. I think we're getting better and better at trying to distinguish these things. But there, in my mind, like in many cancers, there's several advantages of giving it preoperatively. You have the ability to assess disease response, to potentially downstage the patients. And then for those that have like widespread metastatic disease that's not yet declared, it gives you a possibility of that. For your older patients, it's kind of like a stress test too, to see if they're going to tolerate a humongous operation. With a word of caution there, I will say that ovarian metastases don't typically respond to chemotherapy. They just get larger over time, just FYI. Sometimes I've actually gone back to remove the ovaries when people are extremely symptomatic from them, when the primary disease is not progressing or it's remained stable. But typically, don't use ovarian enlargement, progressive ovarian enlargement, as a clear parameter of disease progression, because the mucin just builds up within the kind of cystic area of the ovaries, despite the disease activity. So after all that, appendiceal neoplasms in general on the rise, and we don't really know why. Think about the diverse embryology, histology, pathology, and treatment for these patients. Patients do require a multidisciplinary, systematic, and individualized approach. The treatment will depend on the histopathology, characteristics of the tumor, and the extent of involvement. Cytoreduction for peritoneal involvement is the mainstay of treatment. The role of HIPEC is select. There's really not any good data on appendiceal lesions specifically so for those that have adenomucinosis and have a lamin, for example, we continue to do HIPEC at the University of Minnesota. And I don't typically do HIPEC for colorectal cancer based off the level 1 data and more data, not just the PRODUCE 7 trial. But in general, for colorectal cancer, we're not doing it at all. And for the low-grade appendiceal mucinous neoplasms that can be cytoreduced adequately, we are. Because those patients really don't get any systemic treatment afterwards, and that's the only thing they can really get. The biggest changes is, like I said, the de-escalation and surgical management for the lamins. So remember that, and the neuroendocrine tumors. I think that's something that's going to be an evolving field. Each type of tumor requires a very precise surveillance protocol, and I think centers that have experience with this, patients should be referred to those. And when it comes to the systemic chemotherapy, even when patients have diffuse metastatic disease, if it's low grade, it's really questionable whether those patients benefit from systemic chemotherapy. I don't have a date for our course yet at the University of Minnesota, but for those that want to attend, we're hopeful that we're going to do it in the warm part of February in Minnesota. But those dates are going to be coming out soon, and there's going to be more announcements on social media. Thank you very much.
Thanks so much, Dr. Gardner. I think that was a very comprehensive review, and it was nice to go over basically all the clinical practice guidelines with you yourself. A
Thank
couple of
you.
questions from the chat. Dr. Kaminsky was asking, do you advocate for resection of isolated non-hepatic metastatic disease in these folks?
Isolated non-hepatic metastatic disease? Yeah,
Yes.
so if the patient can be cytoreduced, yes.
Okay.
It this is, I mean, it's not like cookie cutter type of approaches. So when we talk about M1 disease, it's very different when people have like, okay, there's a met sitting on the peritoneum or the ovary versus like there's a lung met or there's an inguinal lymph node met. But if their disease is controlled and we've assessed all the parameters and there's still as long as I can cytoreduce it adequately and the patient can tolerate that, yes, of course.
I had a question. Actually, I had a couple of questions. In your experience, do you find that goblet cell adenocarcinoma of the appendix presents itself a little bit differently in terms of its peritoneal spread? I've heard kind of some just personal experience that it kind of spreads more laterally, not necessarily quite so bulky. Seen it.
Yeah, 100%. This has surprised me earlier on in my career, and I have a partner that saw this recently, and he said, I was just looking at these very subtle nodules
Yeah.
that almost looked like it was just scarred. It was not even like a tumor, a nodule. And I immediately said over the phone, that's goblet cell until proven otherwise. And indeed, that's what happened. I can't speak universally about this, but when you see peritoneal involvement from goblets, it's more subtle. I think it's more micrometastatic, but it's definitely more diffuse.
Okay. You were mentioning there was a lot of data out there about colorectal cancer, and the Prodige 7 trial obviously was pretty groundbreaking in the fact that it was like a massive trial that showed really no benefit to adding the high PEC component, but I think some critics say that it was with oxaliplatin and the dwell time was a little off and the concentrations were a bit different. What are your thoughts on that with the use of mitomycin? I thought that there was a Spanish trial that was going to come out.
It did already.
Oh,
Yeah.
it did. Oh,
Yeah. So, I mean, we could spend another hour talking about HIPEC trials specifically. And that's why I just wanted to kind of tell people that everybody's kind of doing something a little bit differently. It was heavily criticized that a lot of the patients in the Prodige 7 trial were treated at excellent institutions. Most of them got preoperative chemotherapy. They were very select. They used a cutoff of even PCIs above 24 when a lot of the HIPEC trials used something closer to 19 to 20. So they were tackling probably more advanced disease. There's been plenty of data showing that the agent oxaliplatin versus mitomycin, there's really been no difference except for an increased cost. We used oxaliplatin for about 2 years at the University of Minnesota when the cost was much more elevated, and people have significant metabolic and electrolyte derangements after oxaliplatin. And we really didn't see any translation into better outcomes, and that's what most centers did. So I think a lot of people are going back to mitomycin, but that still hasn't been addressed more of in a randomized fashion. The Spanish trial really did not show any difference, and 5FU is cheap and effective, and I think most HIPEC centers are using that. So there's always something to critique about these HIPEC trials, and I'm not changing my practice completely based off one trial. And I get it how a lot of people do, but I think there's a lot of gaps in the data that doesn't make it perfect. And these things have to be individually discussed.
yeah. The Icarus trial will be interesting to see with the appendix arm. I was just kind
Right.
of
If
chatting
they
with
have enough numbers. Yeah.
yeah, yeah. One other question that I had, and then we have one on the chat too, is when I was reviewing the NCCN guidelines a while ago, some very early appendiceal adenocarcinomas can be considered for appendix or just the appendectomy alone.
Especially low grade.
Right.
Yeah.
But I mean, just I think in general, what you're saying is if we're ever presented with something on our colorectal fellowship boards, the answer is not going to be so refined as to like, T1, low grade, no LVI, negative margins. It's going to be just do a right hemicolectomy. Is that
Yes. I
CPG
think the
guys?
safest thing in that situation would be to say to do right hemicolectomy. Because typically it's not going to be like an expert in appendiceal lesions that it's going to be asking you that question. And they probably won't provide you with enough like granular data regarding the histopathology for you to make that decision.
Got it. Understood. Personally, if you ever had somebody who had all of those categories and managed to check them off, which is probably a little unlikely, would you leave that up to them as like a patient physician shared decision, or would you
Yeah, I tell people like, especially if they've had, well, I think about it this way. What's the morbidity of a robotic right hemicolectomy? Like 3% or
no,
less, right?
no,
3%, let's say. Like if it's done electively, patient's healthy, no issues, 3% chance of a leak or something bad happening. If somebody has less than 5 millimeter adenocarcinoma at the tip of the appendix, the chance of that becoming micrometastatic over time, we don't know. I don't think we know. There's not good natural history of that. It's probably going to be less than 5%. So it's equivalent. But think about, do you want to have surveillance and what's going to be the
it's a good point.
imaging for that patient? So personally, that decision making, I tell people about that may be something that's changing in the near future. But my best recommendation is typically to perform a right hemicolectomy as long as there's no like extraneous kind of factors that influence morbidity.
Okay. The question from the chat is from Dr. Eric Mulkey. So he says, if a referred patient by GI after colonoscopy finds a volcano sign at the appendiceal orifice, what would be your workup and management? Cross-sectional imaging followed by a plan for lap appendectomy with frozens, and have prepped for possibly a right hemicolectomy pending on intraoperative findings?
Yeah, I usually image those patients, and if they definitely have like dilation or some cystic nature of the appendix, I typically don't prep those patients, and I do like a laparoscopic partial cystectomy, whatever the ileocecal valve will allow me to. I don't trust intraoperative frozens to determine whether I have to do a right hemicolectomy. And I tell this to the patient before so they don't get extremely frustrated with me. I said, it's going to be a same day operation to imagine it that way, unless there's something that I find that may influence like the actual adenocarcinoma, which rarely happens. But if there was like a little nodule or something like that I could cite or reduce at the same time and it came back as positive for adenocarcinoma. But those are very weird situations. To answer this person's question, I would not prep the patient, do the imaging, not prep the patient, do a cystectomy, wait for the path to come back, and if he needs a right hemicolectomy, I'll bring him back, and you can do it right away kind of situation. So you're not in that, that zone of worrisome postoperative complications, or you can wait 6 weeks and just do it in 6 weeks.
Okay. Any other questions?
I think we'll let you run away to your case. Thanks so much for your time.
Oh, yes. I almost forgot about it.
Good thing we got to discuss it again.
Yeah. Well, I didn't get paid, so that would be great. That was great. All right. Well, thank you very much for having me, and great questions, very insightful questions, and looking forward to participating in this more in the future.
Absolutely.
Absolutely. Thanks for your time.
All right. Have a good night. Thank you.